All right, here we are again for another episode of the Down Fracture Podcast, a podcast for talking jaws. As always, feel free to reach out to downfracturepodcast@gmail.com for any suggestions, topics, cases, and whatnot. We did have an email this week, Sam, asking if there's something we can do about your face.
Oh,
Uh,
yeah, no, you're stuck. Unfortunately, yeah, I think there's probably some computer technology to, put on some better face overlaid mine. Like, don't
like
people
it,
have filters or something? Don't they use
yeah,
filters to
absolutely.
improve their
Well, they
appearance?
they specifically were commenting on the pastiness, but you do have a little color this week.
Yeah, I mean, I live in Seattle. I mean, come on. There's like no sun rays this part of the world, especially right now. But yeah, I mean, it's looking worse than usual. So it's good to see you. It's been a while. A little bit of harassment right off the start. Appreciate it.
So the actual verbiage to finish the email was, if all of us listeners chip in for a makeup artist, do you think Dr. Bobek would use it?
Unlikely. I,
All right, I'll
does
make
your
sure
does
I
your wife wear
include
makeup? Does she
what's
does your wife
that?
wear makeup?
Probably.
There's like a whole routine to that. And I don't know what it is, but there's like a bunch of like you can't just go to sleep with makeup on. You have to do a bunch of stuff. Like,
Yeah.
I don't know.
There's
That part keeps me away from makeup. So sorry. I'll
there,
see
there's
if my
essentially
blurring
like a
of the
warm
background
up and
is
a
doing
cool
me.
down process to wearing makeup. Like you got to do prep to put it on and then
Yeah.
like take it off. And yeah, I'm with you. I'm a little confused by it.
I feel like that's a big one. So sorry about the email person. But I'm sure I
It
can
was,
change the filter.
yeah, you might look into that. Well,
Well,
we
sweet.
already
What are
got
we talking about today?
off anything to distract the topic. I think we would what decided on mandibular nerve injury and repair
Nerve injury is a good topic. This one comes up and it's got some overlap with jaw surgery, so
for sure,
good
for
one.
sure. So
You have
yeah, I
some
mean, I
slides, it
guess
looks like.
yeah, I did. I tried to put together both some images and just like overviews of things I thought we might want to talk about. Like,
Well,
uh,
so nerve repair, in terms of your life, you do nerve repairs, right?
yeah, are you not doing them much anymore?
Well, I had a period of time where I did more of them. Now I just kind of select cases, I would say. So I think I've I was in that world for, I would say, maybe 8 years, something like that, maybe eight, 10, somewhere in there. And then I just been a bit more focused on jaw surgery and TMJ stuff. But nerve repair is a great topic because it definitely comes up, and it's a good one for younger surgeons to contribute in terms of covering some of the more complicated surgery. So,
Yeah. I mean, I think everyone would agree, even those of us that do and those of us that don't do this, is that there's absolutely a need for providers to do this.
yeah.
You can make that case for TMJ, orthognathic, other things too, but this one is one that's definitely underserved to the point where I'm often finding that I might be the only one routinely doing it in my state. There's probably other people who can do it and maybe do it here and there, but I don't think anyone else is really routinely doing it.
Yeah, I mean, if anyone listens to this who lives in Arizona, let us know.
Yeah,
But yeah,
I
same
would
thing
love
in
to know.
Washington. Oregon's kind of the same thing. And I think it's pretty similar in most states, at least. It's hard to find providers.
Yeah, I mean, I would love for there to be other people doing it, and second opinions are always nice. Share the burden, share the load. Not everyone's for everybody, so to speak. Yeah, I mean, I think it's definitely underserved. I mean, and I think type of injury, without getting too much into making this an academic exercise, I mean, I think that's somewhat important from an educational perspective, in my view, as the main point being like a chemical injury being a very acute type of situation where I think what the recommendation is like 48 to 72 hours after like an endodontic or any other kind of chemical injury is the recommended window of time for treatment, which always seems extreme to me. And whenever I try to look up that information and know where that recommendation comes from, I don't really get very far. Do you have any familiarity or experience with that?
Well, at least my understanding is to minimize any further injury because it's always like a wider area, right? Like if they inject
Oh,
the
yeah.
canal with bleach or whatever they use, it tends to, you know, make more sense to get in there. Same sort of thing with thermal injury, ideally swelling, right?
Mhm.
But I don't know, like when it comes to this nerve repair business, I think there's very practical ways where you interact with nerves, like in residency or in other surgical worlds, because it is a little bit hard to get experience in this, but you get experience by doing orthognathic surgery or doing trauma surgery or doing cancer surgery when you're a resident or in practice. And if you have familiarity with the nerve, kind of jumping into situations that are urgent, like an endo injury or a witness injury that wasn't repaired,
Right.
isn't that big of a deal because you want to take those early to the OR.
Yeah, ideally in a perfect world. And I mean, I kind of go around that same pathway. From my perspective, I feel like nerve repair is actually fairly straightforward surgery from a surgery perspective. I think, access, there's some debate and some issues, but like it seems like if of all the things that as a surgeon you could teach yourself to do, putting on loops and suturing a nerve together is one of the more basic things that I don't even think you have to like take a course for.
Yeah, I
Like,
mean there are courses for that sort of thing. I
yeah,
think there's a company that I think promotes those sort,
yeah,
and there's additional education to kind of get up to speed on that sort of thing. But I mean, if you're doing cases and someone needs your help with that, I think it is straightforward surgery if you make it straightforward. You know what I mean? I think the hard part of these things is access and the whole like situation of nerve injury, you
yeah,
know?
access and case selection, to me, and then dealing with these patients sometimes and expectations.
Well, because yeah, I don't think it's just patients. It's also like referring doc and just kind of the situation in general. Because generally, nerve injuries are an unexpected outcome. But even if they're expected, you still want to recover, right? So you want to
Right.
like help the patient recover. And so there's definitely like that part of it in terms of management, and just kind of trying to steer the ship in a more positive direction. That I think has more trick to it than
Oh,
necessarily the
yes.
surgery. But again, you do more of this now than I do, so you should speak to it.
Well, no, I mean, I think everything you're saying is true, and there are obstacles that come along with this, such as the ones that you're saying. Sometimes there are time, there's time constraints if it's a chemical injury, which I've had a run of those probably in the last 6, 8, 10 months. And yeah, you litigation can't go without mention here. You're trying to avoid that by helping everyone out, like you said, steer things more a positive way, kind of reinforce that, hey, look, you can do everything right, and sometimes bad things happen. Trying to settle things down both from the patient, the referral, um, and then I mean, I would steer it to the, setting reasonable expectations for patients is sometimes a difficult thing. I think when you start talking about, a common question I get, and I'm sure you got it too, is, what percent chance do I have of recovery? And so you're going down that pathway of, well, here's what the literature says, but let me be clear on what recovery means or what we view as a success. And I think that's a difficult conversation for patients to understand at times.
Well, yeah, no, I think this has overlap to jaw surgery or orthognathic surgery in terms of expected nerve recovery, right? Like
Yeah.
there's a lot of good literature on what you would expect people to do in terms of recovery after an even a high level inferior alveolar or lingual nerve injury. Because I think that's largely what we're talking about. But I would say that the few situations where you should jump in, like a witness nerve injury or an endo one, getting those guys to surgery. You had some pictures of that, right? Like
I mean, I have some radiographs to kind of show some of these things.
like an
Like,
endo injury, you're looking at that premolar on the right.
yeah, down here. This was a recent one. I mean, I have some other, endo injuries. Like this one was fairly extravagant. Um,
And so in those situations, you get them to the OR within a week. Is that
I
what
mean,
you
I
end up?
absolutely try. I mean, I
Yeah,
think that's a difficult thing at times because I mean, thinking of what all are your obstacles. A lot of times,
sure.
you would hope that someone's taking a final radiograph after a fill, and in dental school, taking me back a long way. We were always taught, hey, you got to be able to see where there's no longer a fill. Like, so you need a film that shows where your fill, you need a film to show where your fill ends. And that's been, I think, a problem that I've seen in a couple of these endodontic nerve injuries is the provider and the patient are completely unaware until it's a few days later and they're like, hey, I'm still numb. And then they bring them back in and then they take an image and they're like, oh, wow, this happened or, this happened. So
Sure.
I think that would be a teaching point if there's any dentists or dental students out there, reinforce that, make sure you have a final PA or pano that shows the extent of your fill because, well, now look, you're what? Well, I'll use this case, which was fairly recent, and this was done on like a Thursday or a Friday, one of those days, but the dentist wasn't in the office the next day, but they were in touch with the patient. The patient calls, says, hey, I'm still numb. They say, okay, that's probably swelling, injury, like whatever, this happens sometimes, give it time. Still numb on Monday, bring him in, take an x-ray. Oh, wow, we've got this scenario. Well, now we're already 3, 4 days out. And a lot of times they don't know who to send him to. And so they
Yeah,
may not
for sure.
find me for a day or two. And
I
then
think
I got
there's
to see
very
the
real
patient.
life
What's
logistic
that?
hurdles. There's very real life logistic
Absolutely.
hurdles on nerve repair situations.
Yes, I mean that whole 48 to 72 hour recommended window, I don't know that that happens in real life most
I
of the
mean,
time.
I think it's a good thing to have as a goal, but I
Yeah.
mean, what you're describing is definitely what my experience was when it came to that. And then there was the whole getting him to the OR can
Yeah,
be a little bit tricky because your block time's full or you don't have block time and the hospital doesn't have staff. You know what I mean? Like
absolutely.
I didn't think insurance was too problematic on these. What's
No,
your give me an insurance update? Insurance is pretty.
no, this is one of those where it's almost like trauma, and they don't even usually require pre-authorization in my
Oh,
experience.
okay. Yeah,
Um,
that's good because that can be a hurdle as well. So in these ones, you take them to the OR, you doing what? Transcervical access, transoral.
I
What do you?
have I have never intentionally done transcervical access. Sometimes you do it for this. Sometimes you're doing access for other reasons and you encounter a nerve, you end up repairing it. But I do these. I can't- I think I've done every single one intraoral when
Yeah, I
I'm
mean, there's
intentionally
pros and
going.
cons to that, right?
Absolutely.
Yeah,
I mean,
because
because we
intraoral
all,
is access is tough, especially if like lips are tight or mouth opening's not the best because they just had a procedure. Um, because I've definitely seen it, and the people I know who do this sort of thing, that's definitely kind of the initial different approaches, right? So from below, I personally always found that to be hard on kind of finding the nerve. And it didn't really feel like it made it that much easier. But again, I don't have a bunch of residents to kind of retract and do everything for me. So I found wow, intraoral was difficult, a little bit easier than transcervical. What do
I
you
think
think?
so. I mean, again, I haven't done it, but I mean, I just feel like that's an unnecessary hurdle. But I will say, as I've been doing more of these, I do find a very common thing to occur, kind of going to a previous topic, is I feel like these people often struggle with mouth opening
Yeah.
after, even if you're doing like a lingual, or you're not accessing through a sagittal split.
Well, it's
I
probably all
find that's a very,
temporalis attack, right?
what's that?
I have the
You're,
opinion that
yes.
attacking the temporalis
Yep.
causes more mouth opening limitation than we think,
Yeah,
like
I think
sagittal
so.
osteotomy and just I don't know ramus dissections, those sort of things.
Yep. I mean, definitely see that a lot. But yeah, I mean, I'm mostly intraoral. I know you're a big fan of the sagittal split to get access to the IA, which I
Well,
will
because
say is better access, but I probably should be doing it more. I try to avoid it when I can, but
yeah, I
it,
mean, because at least on these more urgent ones, you get to the OR. I think the other hurdle, which I meant to bring up, had to do with grafting. Does your hospital have a nerve graft material?
yeah.
And but do all your hospitals have that, or do you just have one in particular that has it?
Yeah, I mean it's a vendor and I call the same rep every time myself and give them a heads up of like, hey, I mean usually the hospitals are good reaching out to him as well, but I give him a
Yeah,
heads up and he just goes to wherever.
I think yeah, if people are thinking about doing more of these or offering, I think just making sure that your hospital has those. Because in my hospital, it's at the Orthopedic Institute, and we have to give enough heads up on the rep to for them to bring product in because those things are expensive. And so
Yeah, they're very expensive. And then I think for my situation, both my hospitals are trauma hospitals to an
Oh, so
extent.
they have it.
And so they kind of have a relationship. And so that to me has not been a barrier, but I absolutely, that could be a barrier. And I think that's a good way of segueing into, how were you repairing these? Because I kind of have a general philosophy now of if basically if I think I've on all of the nerve repairs I've done in the last 1 to 2 years, I think I've used allograft. Um, I think if I could get a tension-free closure, I would do direct repair, but I often find like that's not easily done. And
Well,
so I
yeah,
think
because
I've
like in
grafted all of them.
these kind of early injuries or witness injuries or open injuries, however people reference them now, you pretty much know where the injury is, right? So you can go after it. And I mean, something like this, I could see that graft is probably a good decision. I mean, I don't know. Did you always have cadaver grafts? Did those always exist in your world?
I in residency we didn't use them.
Yeah.
But I can't recall actually harvesting an autograft in
Yeah, because I
residency. It
think
was
it's
always kind of
relatively recent, like maybe 10 or I don't know when those
yeah.
came about, maybe like 15 years ago or something.
Hmm.
And just having those available sure is nice because you can
Oh
get
my gosh,
tension
it's
free
amazing.
closure is like the thing.
Oh man, it's huge. Yeah, I
And
mean, I couldn't
so,
imagine harvesting these things. Like, I don't think I would do it if I had to harvest them, to be honest, at this
I mean,
point in
because
my
you're
life.
you're giving them a definite another numb spot or
Yep.
a
For usually a size
less numb spot.
mismatch and a fascicular mismatch, a lot of times. I mean, it's just, I don't think I'd do it.
So these endo injuries, the one that you have up here, I had perceived those to have a little bit more pain. Is that what you encountered?
Yeah, most of the time, but it seems to not be immediate often. I feel like in the ones that I've seen recently, like half of them have been like immediately they have the dysesthesia, hyperalgesia kind of thing going on. And then the other half is just numb. But as we kind of, again, and when real life happens and we get to them, sometimes 2 weeks out or close to it, they tend to start having it. The longer out from the time period out from the injury is what I've kind of noticed. Has that
Yeah,
been your
pain's a
experience?
bad one. I mean, um, pain's a good indication to repair nerves or at least do something.
Absolutely.
Because pain's worse than numbness.
No, no doubt. I mean, I think
So
that's where the other thing to hit on here is case selection, and I think that's the easy one. I think the two extremes are dysesthesia that's just debilitating. Like that's an easy decision to intervene because the worst case scenario usually is making them numb, and they would trade that any day of the week.
yeah, or I think probably worse is that you don't improve it much, right? They
Yeah,
still have pain.
I haven't come across that myself. Um, personally. I mean, I've read some stuff, but usually I haven't had persistent dysesthesia that I can recall.
Yeah, no, I agree. I think when it comes to this stuff, there's only a handful of people that have like honestly large numbers, and I'm not all that sure how large those numbers are.
Well, I
Um,
have some here if you want to look at them.
yeah, bring them up because like jaw surgery or TMJ replacement. There's totally people out there that have done more than 1,000, right?
Mhm.
And centers that have big numbers when it comes to that nerve stuff. I mean, you're bringing up the Atlanta,
The Gary paper here, yeah.
Zemery from
Yeah. Yeah, I don't have the whole thing on there, but
yeah, but this Gary's papers, he's an old Oregon fellow, by the way. I don't know if you know that connection. It was like I was like an intern, I think, or maybe even like a dental student is when I interacted with him.
no, really, I didn't know that.
Um, but anyway, he has some just classic papers on nerve recovery, right? And you pulled up this one, which is in JOMS, I don't
Yep.
know, like '08 or something,
I can't
'09.
remember. I kind of was quickly putting this together from like the handful of nerve papers that I have in my laptop. But
Yeah,
I
and it
mean,
just followed the outcome in terms of recovery after nerve repair.
yep. And I mean, this was pre allergenic graft, so no oxygen, no any of that stuff going on here.
Yeah. And so what this thing show?
Yeah, I mean, I think the take-home points that I've done, and I've kind of pieced some things together to create my own philosophy, is just some of the. some of the stuff that I have struggled with, and it's always a question is timing. And so one of the things on this one is they kind of said that their mean time to actually operating on these nerve injuries was close to 11 months post-op. And you're always taught, at least me, I always try to do 2 to 3 months for lingual, 3 to 4 for IA, as far as timing. But most of theirs were close to 11 months out, and they still had an overall success rate of 82%, which
Oh,
I
so
thought
yeah,
was,
so I think this is good to understand in terms of making the decision on when to
yeah,
operate, right?
yeah.
Because the non-witnessed injury, the nerve, the numbness after sagittal osteotomy or numbness after wisdom tooth removal or numbness after dental implant, right? Like how
Mhm.
long do you wait?
Yeah, I try to go by the 2 to 3 for lingual. If there's some circumstances where I would go quicker, and then I kind of try 3 to 4 for IA.
When would you go quicker?
If they have, the decision would be if they have the typical kind of signs and symptoms of like neuroma formation. So, hey, I was completely numb for a few weeks, and then after a few weeks, I kind of got this really bad dysesthesia. And I'm probably quicker to go to lingual than I am IA for obvious reasons. Being out in the soft tissue, it doesn't have that kind of conduit of the canal or, the bony surrounding structure to help it heal.
Sure.
So if they were just numb in the lingual and they stayed numb, I'd probably do 2 to 3 months. If they had that kind of classic neuroma type symptoms that are described of, like I was saying, numb initially, a few weeks later, dysesthesia, hyperalgesia, hyperesthesia kind of stuff, where they're, in daily debilitating pain, I would probably go sooner. But even with these, I still find that life kind of gets in the way because I'll throw this variable at you. Like, I'm not real comfortable, even though people might be good at it. I'm not real comfortable taking other people's neurosensory exam at face value. Like,
Yeah, for sure.
I want to test them more than once myself,
Yeah, yeah. Because I mean, the
typically.
referral to someone who repairs nerves, if you have some residual numbness or dyesthesia or something, make that referral early, right? Like, I
Yeah.
mean, it doesn't hurt to load the ship a bit. That's Holmgren. I learned that term from Holmgren, by the way.
Is that one of your old man sayings, or are we going to count that?
He was I think he was like on one of our first episodes of this thing, Eric Holmgren. He's a
Yeah.
surgeon. He was my chief, and it's like getting some help when things are going in a different direction than you'd like. So if recovery of the nerve is different than what you'd expect with just injection injury, then sending them to a nerve repair for a person for an exam early is helpful.
I think so, because I mean, again, the people sending them, the typical pathway is either this comes from an oral surgeon, from a wisdom tooth and implant, or another dental provider who then sends to kind of a local oral surgeon to evaluate. And then if they feel like it's recommended, then often they will send to the nerve specialist, or at least that's kind of how it works in my world a lot of the time.
Yeah.
But what I don't like, I guess I probably shouldn't word it that way because at the same time, I don't want to see every neuropraxia. I don't want to see every patient that has some hypoesthesia. So I do like that they test them and they wait. But, sometimes I see them at 4 or 5 months and I'm like, I want to test them at least twice and have some time interval between that to track it. And I feel like that's too late. But, do we need to see everyone at 3 weeks, 4 weeks when they might still be getting better? I
I
don't know.
mean,
I think
I
that's tough.
I had heard, and I think this is reasonable at a month to give it a month and then send it over. I mean, I think for a lot of oral surgeons, you're kind of used to the normal path of recovery, right?
Yeah.
And the normal path of how nerves wake up after, like a mild to moderate
So
injury.
you're saying at a month, you feel like if they're not getting better, like what if they're getting a little bit better?
Yeah, that's the thing. I mean, getting a little bit better and the patient's kind of understanding is on board with it. I think, watching or referring over to someone that um, if they're having a hard time with numbness and, maybe wanting intervention and wanting referral and then sending it off makes a lot of sense.
Yeah,
Thanks. Because I mean, there is that, right? Remember that,
absolutely.
like the
But I find that
hard part of
tricky.
this is that.
I find that tricky. I feel like, just like we're talking about the obstacles that come in with these kind of more immediate need for repairs, I feel like that obstacle is real too. In that, again, the other key points from this Spigeri paper are they did kind of see what they described as a linear decline in success rate over time. So while their mean time to operation was 11 months and still reported 82%, they kind of had a linear decline over time. So, I mean, you do want to get them as early as possible, within reason. And I find like that can be a challenge too.
Yeah. So I think because at least my impression of that, and I think it's true, is success is functional sensory recovery and complete sensory recovery.
Yeah,
And so if someone's at functional sensory recovery going into surgery, that's like I would have to believe that's why you're waiting, right? And this
I would
paper looked
hope.
at like, well, what's too long to wait, right? Like,
Yeah, well, I mean, trying to predict that scenario, I mean, it also could just be, again, maybe they didn't get to them, like maybe they weren't referred for a while.
yeah, for sure. But I mean, if someone has no sensation or they just have dystocia, and that's sticking around for months, it's just a different scenario than the gradual improvement in their clinical
Right,
neurosensory
right.
exams. If they get to functional sensory recovery, it's very much like, well, is it worth the repair? And that discussion is a good one to have with you. So I mean,
I know, I don't think so. I mean, that's kind of my threshold to not do it. Like that's one of my cutoffs. Are you
for
still
me, I wouldn't do it
repairing if
either.
they're at FSR?
Yeah, because I think that's another nice thing about seeing someone early is you can start kind of like framing the picture of what to expect in terms of recovery. And so it isn't like complete 100% return of sensation. I mean, obviously
Right.
that's great if that can happen. Um, but kind of understanding how these things heal and if we do an intervention, how that would improve or worsen it, right?
Right.
So,
Yeah. So, I mean, I think before we get off of this paper, I mean, I think let's just point out the couple of, I think, take-home points from an educational perspective and kind of how I utilize these and explain it to patients is, yeah, over time, there's a steady decrease, a linear decrease, and after a year is what they found. But again, I think that differs from what we're traditionally taught. They're saying the cliffs where there's a drastic fall off for about a year after
for
injury.
successive repair.
Exactly. Yep.
Yeah.
And
So if
then,
you because I mean, you do meet the people that, or I meet them that had jaw surgery in the past, and they have total lack of sensation on their lip and chin or their tongue or something, and it's like 4 or 5 years after, and I mean, the thought always pops into my head: should I try? You know what I mean?
I don't think if they're completely numb or they have dysesthesia, in my opinion, there's zero harm. I don't think it's unethical for one thing, or I don't think there's any harm in trying as
Well,
long as the patient is reasonable. Like
yeah, I mean, because by that stage they would have already gotten somewhat used to it, right? Like they
you would hope.
generally used to it, and then this the Bagari paper argues against a late repair just because of the likelihood of success. I mean, that being said, if they're totally numb on, let's say, an infraalveolar nerve and you're doing a revision sagittal osteotomy anyway, like doing a nerve repair at the same time, like
Makes a
I
lot of
could
sense.
understand that. But
I think it makes a lot of sense.
I mean, it does complicate an already complicated scenario. So just as a heads up to anyone who's thinking about that one. I'll
Yeah.
speak to experience on that. It complicates a complicated scenario. So
Yeah, for sure. And then, I mean, I think the other point is they specifically pointed out after 51 years of age. I actually had a patient bring this up to me the other day. Hey, I'm older than 51. What do you think? And I was like, where did you get that number exactly? Like, why not? Why wouldn't you just say 50 or? So I guess they found this paper as well.
yeah.
So yeah, that's where they kind of saw more steady drop-offs a year after injury and in 51 years and older based off
Yeah,
this.
so we are the ones that we kind of jump in early on the people. It's nice to refer them over, so I'll send some people your way.
No, thanks.
You do some serial exams. You talk to them about repair. Only in situations of total numbness or unacceptable. I'm sorry, total numbness, pain, and unacceptable paresthesia. Let's say. Um, so yeah, getting back to the access because we got into the access, but kind of derailed it there somehow.
Yeah.
Access, what are you doing now? You taking off buccal plates? Like,
Oh, you and I have talked about this, and I know you're a big proponent of the sagittal split, like we were talking about earlier. And I will say it really is the best access. I just struggle with making like subjecting patients to that.
It is the best access.
And by far. Now, again, it kind of depends on where we're talking. Like I got, an image here. Even getting this far back, a SAG is probably reasonable. So I think to answer your question in as honest a way as I can, it depends on the location of the injury and the extent of the injury. So, like if it's a chemical injury in the posterior, especially, I think you got to do a SAG. You got to do the split because you don't know how far that injury is going to go if it's chemical in nature. Because, like you were talking about earlier, it's always further than it looks on radiograph.
Well, I mean, I definitely agree. I think the X-ray that you have up is someone who has an implant on a first molar in the left mandible that's looks like the source of injury,
Mhm.
but also has fairly severe arthritis in their joints.
Yeah,
With the problem with SAG access is you don't want to give them a new problem, right? Like,
exactly.
because then their mandible needs to heal, and then you got to be comfortable cutting SAG, and you don't want to create a second nerve injury, right? Like if that's
Yeah,
a
that's a real
possible
problem.
outcome with your sagittal osteotomy, maybe that's not the best choice. You got to see condyles, mandible needs to heal. So yeah, I think SAG access is great to see the nerve, but like in this one, I'd be a little worried about it myself, just because I mean,
Condyles, for
you,
one thing.
yeah, because you're the man. I think you got to carry the sag pretty anterior, and then you got to put some plates on it. You pre-plate it, and you're going to dissect the metal framing out quite a bit. And in my mind, am I really being that nerve friendly? Um, but like second molar and third molar, for sure, sag is great.
I think you have to most of the time on those, as much as I hate it. I mean, otherwise, I try to take buccal plate off and then, remove the cancellous bone from the interior
Yeah,
aspect of it and then plate it back at the end. But I mean, I've had issues with that. I've had those not heal well. Even though you're trying to go monocortical through a buccal plate, you have a kind of this tension-free nerve underneath there that can catch a drill. You know where it is, you're visualizing it, you're trying to put in screws or plates, avoiding it. But I mean, I could see you tangling up a nerve in the drill,
yeah.
puncturing it,
I mean,
all sorts of problems.
all the possible nerve injuries that exist by taking like harvesting bone from the ramus or doing a sagittal osteotomy still exist by accessing
Yeah,
the nerve.
absolutely.
Um, yeah, it's I think for me at least, like I don't want to be making the situation worse. So it's like, how can I make this better? And I don't know, in this first molar, I think probably just accessing laterally and freeing up the nerve from the metal frame and back and working on it.
Yeah.
It's just, man, you need a lot of hands to do that. Like who you because you have your two hands, obviously. What else you got? You have
Usually
associate.
either a scrub tech or sometimes a resident. Um, sometimes I have some extra hands, but I feel like I mean, I've taken buckle plate off and left it off.
Yeah.
I don't know that that's the best scenario either, but I've done it. I mean, I find that that's not, I feel like the Sag, I feel like I need more hands for the Sag than just taking the buckle plate off. You don't think
Yeah.
so?
I mean, because there is that. I mean, because the extra hands you need is retraction, and you can like self retract to a certain extent because you do need to use pickups and the needle
Absolutely.
at some point. Like if you're tying the graft on, or if you are tying on a nerve protector, or however you're doing it, you need to use two hands. And then you have suction that's also another hand, right?
Yeah. I mean, I find that, luckily, usually they're pretty dry. You do the Sag, and I feel like you might be opening a can of worms for more bleeding, but lingual, usually bleeding's reasonable. Taking the buccal plate off, usually get it to calm down. Um, the
Yeah, because a
sagittal
lot of like
split.
self-retracting is helpful. Like lingual, tying the tongue back to the bite block, sagittal osteotomy. I think toe out into yank hour as proximal as you can get them tends to
Yeah.
keep things out of the way.
The other trick I did the other day, I think I talked to you about it, is for lingual, it might be part of why the patients have some decreased opening, but I kind of did the double curved coker, clamp it on the ascending ramus,
Yeah, totally.
the Alice clamp and chain to kind of give me superior retraction so that no handed was needed there.
Yep.
And then, um, yeah, I've sutured the tongue to the bite block before. I think that can be helpful. Um, I've sutured the flap, the lingual part of the flap as well to just kind of have it held. I don't love that. Sometimes it can tear.
I I used to, I liked I probably would still like this. I liked pre-suturing the nerve before I put it in the mouth. Because
Yeah.
I mean it's just hard. It's
Yeah.
difficult. I mean, I used the microscope for a period of time and I realized just how much harder it was making my life. Just because you also lose some vertical space because it's only so much room and so instruments will bump into it and it's like it's already hard accessing from the mouth. And so loops allows you pretty good visualization, keeping it as dry as possible, auto retract, suture outside the mouth as much as you can. I don't know. I found Tissille to be useful. You use Tissille at all or no?
I haven't. I know it's
You don't
nerve
like it?
friendly, and so it wouldn't be the worst thing, but I haven't. Oh,
Yeah.
actually, you know what? I take that back. I have a couple of times when I did like nerve wraps around them as well, just to kind of help make them more stationary and stable around the
Yeah.
repair. I've done that a time or two.
Because there's a whole discussion about like, you know, leaving a gap for nerve repair versus having the nerves touch each other versus using a
Yep.
connector, protector, all that. I think that's for another day. But I think generally with these, I would float the idea of the sagittal osteotomy because it's sweet.
Yeah. I mean, as much as it pains me, I would agree with you. I think if you're just asking the question, what gives you the best access? I think it's unquestionably the SAG. It's just the can of worms you sometimes open with that. For lingual, I do it all intraorally,
Yeah,
lingual sulcular incision, and then take it back behind the distal molar and
sure.
reflect. I mean,
What do you
all
got up
that kind of
now?
stuff.
You have a
Yeah, so I mean, this is kind of the other. I was trying to, I couldn't find the paper that I actually wanted. Maybe I deleted it or never saved it. But basically, for my thought process, my algorithm, so to speak, is if I can directly repair it, I do. And if I can't or there's going to be tension on it, then I do allograft. And the decision making for that was, I've read a number of papers that kind of report on the success of the allograft. And so my understanding from what I've read, and maybe there's newer stuff out there that disputes this, is from direct repair, autogenous graft, and allograft, the results are like equivalent, maybe a percentage point or two different.
and
But
this
like
is
trying to
for
use
peripheral or lingual or for
both
peripheral.
for both, and where you get decreased success is trying to use like conduits only, and like you're saying, there's a gap, and you're just trying to provide it like a scaffold to self heal. So that's kind of how I came up with my protocol of, which I think most people do, of like if I can direct repair, I do. If not, I try to use allograft. I don't try to just put the nerve close together with a wrap or a conduit or anything like that. I try to have pretty close nerve to graft or direct nerve to nerve contact. Uh, so that's kind of my decision making on that, which again I think is probably standard at this point.
Yeah, I mean, I think that hopefully our discussion, I feel like there's a lot of opportunity to jump in and do these sort of things. But at the same time, there's like a hesitation because, you haven't done like 1,000 of these.
Right.
Um, I just don't, I mean, there's, like Maloro and just, there's people who do a good chunk.
Zuniga.
But everyone can't travel to Chicago, like
Right.
you got to help people out in Arkansas and,
Yeah.
like Alaska.
No, I mean, I think for the resident students, young surgeons out there, I think this is a great avenue to grow your practice because I mean, I say that about TMJ surgery, other things, but I mean, you're not typically competing against many people. Like, not a lot of people want to do this. It's a good service. Um,
Yeah,
with
I think you probably develop some of those skills in residency. Or if you haven't, it's easy to catch that in other overlap situations.
yeah, I mean, as I said before, I think this is something I didn't get a ton of experience in residency. I don't know how much you did either, but like I think this is one of the easier things to learn from a technical perspective. And that's not to say that suturing these nerves is easy, because it's not, but it's fundamentally a very simplistic kind of approach of you go to the injured nerve, and if you can access it, which I think most of us should be comfortable doing, you should be comfortable getting into the mandible, and you should be comfortable kind of dissecting out the lingual nerve.
Yeah.
I feel like you should be, and then it's pretty easy. You find the damaged, bad, pathologic nerve as best you can. You cut out the bad and you replace it with good. I mean, like it's a very, most of the time, very simplistic, fairly simplistic
Yeah, you end up
approach.
taking, you want to take more nerve than you think and
Yeah,
just get back to where the fascicles look healthy.
healthy
I
and
think a tip that I learned from early nerve repair in my career was to not use a Fraser tip suction.
yeah, you can wrap
Uh,
it up easy.
just sucked my nerve graft right up
Yep.
on one time, and I'll, it was obvious after the fact that using a different suction is helpful there.
Mhm.
But there's just stuff like that with every surgery, right? Like,
Yeah.
you just kind of pick it up by doing it. Um, but yeah, I mean, I think that in training, you kind of get a lot of access to this. You had some in training with orthognathic surgery, right? So like a witness nerve injury during jaw surgery. What do
I
you think
mean,
of
I
that?
would say that was fairly uncommon.
Yeah, it is an uncommon event. Uh,
I mean,
but
I have done it on my own. Um,
in
the,
residency, you didn't see that?
if I did, I was unaware. I don't. I would say it doesn't jump out at me. We definitely weren't pulling out the allograft or harvesting nerve, and I don't really remember anyone directly repairing it or reapproximating with a suture. Now, it probably happened, and it escapes me,
Yeah.
but it was not a frequent thing
Yeah, I
by
mean,
any means.
because it would come up. I think it probably came up the most in residency of repair, and then at different points along the way, where the metal framing exits, where the Dalpont vertical cut happens, where the Hunsuck is, the different spots can be variably challenging to access, right?
Yeah,
Um, but you would get the experience of doing that because the right time to fix that is then.
absolutely.
Do you have much experience in the later numbness after sagittal osteotomy, like
As
repairing
far
that?
as repairing it,
Yeah.
I was going to ask you that same question, because I have not, that I can recall, gone in to treat a nerve injury from a sagittal split. Because I
Because
think
it's
there's a lot
tricky.
of difficulty to that, right? Because unless you did it yourself, and here's the thing, like if I did it and knew where it was cut, I would have repaired it right then and there.
Yeah, yeah.
Like I would have already done the repair. And now if it wasn't you and the other person, I mean, let's be real. I mean, you want to hope the best for other people, but if someone else cut it and didn't repair it, they're probably not putting that in the op note.
Yeah.
I mean, some people might, some people wouldn't.
I mean, yeah, because it could be that they didn't witness it, right? It
Yeah,
could
they
be
may not
that
have
you just
known,
you
they
were
may not have
unaware of it.
seen,
I mean,
they may
I
not
can
have,
believe that happens.
they may not have been comfortable repairing it, or they thought it would heal, or so you don't know where the injury occurred most of the time. So what are you going to do? You're going to, as you said earlier, you're going to go do another sagittal split and possibly cut it more proximal on your own.
Yeah, because it would have to be the crew who has total numbness or has pain, right?
Oh yeah, for
And a
total.
lot of people who go through a sagittal osteotomy or ramus osteotomy or have already heard so much about residual paresthesia that they're at least unsurprised by that outcome. Um, but I mean, if you have total numbness, trying to figure out where that source is, I mean, I think it's worth an X-ray, and it's definitely worth an
What do you mean? Like, what do you
evaluation.
mean by
Like
X-ray? Like you're going to get a CT, or you're going to get like what, MRN?
CT, I don't think MRN is all that great for following infraalveolar nerve because I mean, I don't know the ones I've seen. There's like some obvious reasons for that, like screw, compression. I can't see the canal.
But
Um,
how reliable is that though?
infection.
Because I mean, if you've done a SAG and it looks like you put a screw through the canal, well, the nerve, like if the nerve was freed up or mobile, like all you can see is the canal. You can't see the nerve. Like,
Yeah, for
how
sure. Because
confident
yeah,
are
it
you
could
that?
be in a different location.
Yeah,
But I mean, clinically, if they have no sensation and there's a radiopaque object in where the nerve canal would be, it's pretty reasonable thought that that's the the thing.
Maybe. So, I mean, are you saying that you go in and try to resplit those and repair them?
Um, so I actually would be more open to that than other ones, just because I feel like total numbness after sagittal osteotomy, at least in my world, it's such an unusual event or pain even that I think people get told that, that's just kind of how it is and you should just
Yeah.
live with it. But I do think that's worth the referral. I think if it's 6 months, like after a sagittal osteotomy and you have total numbness, or if you have pain or something, then if you were thinking I'm just going to let them live with it, that might be worth the referral to send them off to someone to talk to.
Really? See, I mean, for me, that's a tough one. If they had pain, if they had dysesthesia or hyperalgesia, they had a daily deterrent interruption of their life from a pain perspective. I don't even know. I mean, I guess I would consider resplitting, but it'd be from a dysesthesia standpoint. I would just consider trying to go dissect out to the lingula, clamp it, cut it, give them give them numbness, get rid of the dysesthesia, give them numbness.
Yeah, that's an underappreciated operation, by the way. I think we've talked about that. Like I've used it in cancer patients and whatnot, and
Mhm.
um, just ligating the nerve, I think is nice. But I mean, oftentimes people are going through a sagittal osteotomy to improve their life in some way for breathing or occlusion or aesthetics. And so, accepting total numbness probably isn't their first choice. Because you can still give them that by at least exploring the nerve.
So, I mean, do you have experience in having done that and seeing them improve?
I don't have a ton of experience with this. I've a little bit, but not enough to be like, you should always do that. I think most of the time, though, people are counseled that, you can have total numbness after this. And if you do, it's just kind of one of the risks of the operation. You just kind of get on with life.
Definitely. I mean, I think so. I mean, but I'm just trying to picture this. I'm going to go resplit it, which is going to be, that's already a revision case. It's a little bit of a difficult procedure.
Yep.
Resplit it. I mean, then what? You're examining the nerve all along the pathway that you can see. And if it's really proximal, you might not even really be able to repair it anyways.
Well, so this again, a situation of total numbness or pain, right? And if you find something that's most likely the cause, like bone compression, there's no canal, there's hardware in the nerve, something like that. Because otherwise, if it's just kind of exploring the nerve, I think you might find multiple spots of injury.
Yeah.
And then you
Well,
just put a giant graft in there.
one last question I'm going to ask you because we're getting close to time here, and I know
Yeah.
our audience, as well as us, have minimal attention spans. And we haven't even gotten into many old man sayings today, so they're probably
I
bored.
mean, a little bit.
I
But
mean,
yeah,
yeah,
I
they're
mean, I
probably
feel
bored.
like you're the old man saying expert. So
Yeah, but you're the old one.
that's on you.
Yeah, fine. Um, how are you feeling about external neurolysis alone? So let me give you a scenario because this is one that I struggle with and I'm not real comfortable with. So let's say for the sake of argument, lingual nerve injury, you go explore it and it just seems like there's some periosteal scarring against the nerve. Are you comfortable just kind of removing that scar and leaving that nerve like that? Because that's described frequently in textbooks and literature of sometimes, hey, external neurolysis alone may be all you need. And there's fairly good reports from doing that as far as outcomes. Are you comfortable with that? I'm not. I
Well,
will.
I'm not comfortable with in that scenario of like cutting the nerve out.
No, no, no. But like if you felt like you were just freeing up the nerve from the surrounding tissue.
Yeah, and I mean, if you get like an 11 blade and make incision in the nerve and everything looks healthy,
Yeah.
um, I think wrapping it or leaving it alone, I'd probably do that. I feel like I feel comfortable with that more so than I'm gonna take out a segment of nerve and then I'm gonna graft there. Are you grafting that?
Yeah, see, I mean, for the first thing I would say that's probably an infrequent scenario. Like, I don't know that I've encountered that exact scenario. Most of the time when I get to the lingual, it's a huge ball of scar and neuroma all mixed together.
It's
Um,
actually like I found it to be really disconcerting when you get to the spot where you assume the nerve injury is going to be, and then the nerve doesn't look that bad. And it's
that,
like, am I
that's kind of what
wrong?
I'm getting at. Like, because what makes me uncomfortable about that is just closing them up and saying, okay, we're going to watch for 6 months, and if it's not good, what are we going to do? Go back in and then do a repair? So I'm
Yeah.
almost the opposite of you. I think if if I feel like something doesn't look good or it was attached or scarred, uh, I am kind of, I think I tend to lean towards excising some nerve there and either directly repairing or putting a graft in. Because I don't want to just free it up and remove stuff and then think that that's good and close them up and then they're not better.
Well,
Like
yeah, but I mean, yeah, like you said, people report that people are better after that. And I mean, helping the body heal, doing minimally invasive stuff is good. But if there's still none, then you could always go back and do that as secondarily, right? You could
yeah, that's what I
bypass
mean.
the
Like, I mean,
repair.
I don't know that people would agree to that. Like, hey, this didn't work the first time. Like, I don't know that most patients are going to be accepting of that. I mean, that's
Yeah,
kind of like my attitude, I guess, would be like, hey, I'm here. Like, let's do something, to
always
try to make it better.
that decision is always hard. It's like any of the stuff like condylar resorption and TJR, right? Like the philosophy of just kind of doing the lesser invasive and running with whatever downside to that versus doing the thing that's
Definitive.
gonna seemingly gonna work the most, even though it's the more invasive. Yeah, I understand. Like that decision, I could see why you'd practice that way for sure. So I mean, I don't think it's wrong. I feel like that's good. I just
Did this say, damned if you do, damned if you don't? Does that count like as an old man saying?
yeah, I think so. Although I know that one. So it can't be. I mean, I feel like you have a little southern flair to the old man sayings. And so I don't think that one sounds like a southern.
No, I think that's pretty universal.
Yeah.
Yeah, I'll have to think of some more that maybe
All
universal.
right. Well, yeah, so next week. I mean, we've been off for a few weeks, so it's good to get back into it. We'll get back into our weekly schedule. We had our little bit of ski vacations. You made it all right.
Yeah, barely.
Sweet. I did
Barely,
as well.
barely.
So it was good. Kind of getting that out of the system. So
For sure.
we're back at it next week, Monday.
Hopefully, yeah.
Sweet.
All right. Well, as always, another episode of Down Fracture podcast for Talking Jaws. Down Fracture Podcast at Gmail. Feel free to definitely hit us up. I think the emails insulting you, we should be pro that and
I mean,
plugging that. It does add some
I'm not anti that. It's
entertainment
pretty funny.
value.
Yeah, yeah, no,
Uh,
it's pretty fun. So
I mean, you were crying off air beforehand when I read you this. So I don't know if you can take it, but we'll keep it up. All right. Well, thanks again. See you next time.
all right. See ya.